Welcome. In this lecture, we'll be discussing immune thrombocytopenic purpura. Let's first go over a brief overview of ITP. ITP is the most common cause of thrombocytopenia or low platelets in both children and adults. This is now broken up into two types. A primary type is an immune-mediated thrombocytopenia without an underlying cause, also known as an idiopathic thrombocytopenic purpura. The secondary type is going to be an immune-mediated thrombocytopenia with an underlying cause. These underlying causes can be autoimmune, such as lupus, infection, in which the two most common causes are HIV and hepatitis C, or different types of malignancies, such as CLL. It is important to know that immune thrombocytopenic purpura used to be called idiopathic thrombocytopenic purpura, but now it is broken down into both primary and secondary causes. Let's now go over a brief pathology review of ITP. Simply put, ITP is caused by IgG antibodies directed against platelet surface antigens. These platelet surface antigens can be GP2B, GP3A, etc. Overall, ITP is a type 2 hypersensitivity reaction. Remember, type 2 hypersensitivity reactions are also known as cytotoxic hypersensitivity, which is an immune reaction in which the antibodies target antigens on the surface of cells, leading to the cell damage or destruction. That's exactly what's going on here. These antibodies are targeting these platelet antigens, leading to destruction. Here's a brief overview of exactly what's going on from a pathology standpoint. Here, this in green, we have IgG, which is binding or picking up these platelet antigens, GP2B, GP1B, etc. Once these bind, you have an FC binder portion or an FC region of the IgG. This binds an FC receptor on macrophages. The macrophages pick this up and brings them to the spleen, where they undergo phagocytosis in the spleen. These macrophages now mark these platelet antigens for destruction. So again, in simpler terms, the IgG picks up a platelet antigen. This is then absorbed into a macrophage by the FC region binding to the FC receptor. These platelet antigens are marked for destruction and are thus destroyed, leading to thrombocytopenia. Understanding this brief overview is very important to get questions right on test day. Now let's go over some symptoms. Usually, ITP is asymptomatic. Now, in cases like this, it is important to know what to do as a next step. When you see someone is asymptomatic and you expect ITP, sometimes I'll ask you what is the next best step or what should be evaluated for. If they are asymptomatic, we always screen for two viruses. These two viruses are either going to be HIV or hepatitis C. These are two very high-yield diseases or viruses, as these can be treated for and should be identified as soon as possible. They sometimes begin or mask themselves with just asymptomatic thrombocytopenia, thus should be caught and evaluated for on test day. Now, a little bit more common presentation that you might see is an individual that has some sort of stressor, such as a prior illness. This causes an autoimmune activation, cytokine release, IgG antibodies are produced, etc. And then they develop some sort of skin issues, such as petechiae, purpura, or ecchymosis. Here's an image comparing the three of them. Here, we have petechiae with dots that you can't really even see. These are the smallest, pinpoint spots that are typically less than 2 millimeters. Purpura, on the other hand, which is seen over here, you can actually see these dots. These are flat spots between 3 to 10 millimeters. And then, of course, ecchymoses are going to be the largest, typically greater than 10 millimeters or 1 centimeter. And this can also be sometimes used or described as a bruise. So thus, the only thing that differentiates these three things are going to be size. Petechiae less than 2 millimeters, purpura between 3 to 10 millimeters, and ecchymosis greater than 10 millimeters. In severe cases, when the platelets get extremely low, we may see signs of bleeding. Bleeding can be depicted as epistaxis, nosebleed, hematuria, or blood in the urine, and of course GI bleeding as well. This is typically for severe cases and can sometimes be important to look for on test day, as it can depict treatment. But usually you'll see someone who's asymptomatic maybe with a bruise here or there, with the only lab finding really going to be low platelets. So how exactly do we diagnose this? Well, as we now know, there's a primary and a secondary cause. Thus, we have to diagnose this based off a process of elimination or a diagnosis of exclusion. We look for everything that can potentially cause ITP, such as malignancy, autoimmune, etc. If they want to demonstrate ITP, they'll give you normal CBCs and normal CMPs. The only thing that will be out of sorts will be thrombocytopenia. Thrombocytopenia is typically described as a platelet count less than 150,000. For the case of ITP, we use the number less than 100,000, which is significant thrombocytopenia. What you might also see is you might also see increased megakaryocytes. Now, megakaryocytes are increased in the bone marrow as a typical compensatory response to peripheral platelet destruction. The marrow responds by producing more megakaryocytes, which are thought to be the precursor cells that generate platelets. Please note that this is found on bone marrow, and this may or may not be given to you on test day. Again, we do not need a bone marrow biopsy in order to diagnose ITP, but we do need it in order to rule out other causes. You may also see enlarged platelets due to the bone marrow releasing premature platelets or even sometimes megakaryocytes, which will be larger than regular platelets. It's important to know these two things, as sometimes test questions may demonstrate to you ITP, and they may ask you what is another abnormal lab finding that may be seen. You will, because of the low platelet value, also see an increase in BT, which is known as bleeding time. What will this not have? Well, this will not have an elevated PT or PTT, as these are associated with the coagulation cascade. This can sometimes be seen in liver damage or liver changes, which can also cause thrombocytopenia. You will also not have signs of hemolytic anemia. This is important because hemolytic anemia plus thrombocytopenia is equal to something known as TTP, or thrombotic thrombocytopenic purpura, which we will talk about in another lecture. If you see any of this, it cannot be ITP. ITP will be someone who's asymptomatic with bruising, and the only abnormal lab finding will be low platelets. So how exactly do we treat these individuals? Well, treatment is based off of if someone is an adult or if someone is a child. So let's first talk about adults. Adults are going to be depicting treatment is going to be based off of symptoms. Are they bleeding? And of course, platelet value. Remember, what we said was in severe cases, bleeding can occur. Low platelets, severe low platelets can cause bleeding. The platelet value that we typically use is a significantly low value, typically 30,000. So if an adult individual comes in and their platelets are greater than 30,000 and they have no bleeding, then we typically can just observe this. If there's asymptomatic, there's no reason to rock the boat and try and treat them if it's not causing any problems. But if the platelets are less than 30,000, putting them at a severe risk of bleeding, or they are currently bleeding, hematuria, GI bleed, etc., then we can treat them with either intravenous immunoglobulin or corticosteroids. Steroids suppress the immune system activity. Remember, ITP is caused by autoantibodies. These autoantibodies target platelets, leading to their destruction by macrophages in the spleen. Corticosteroids can reduce antibody production and decrease macrophage function. This slows down platelet destruction. On the other hand, it's important to know with IVIG that this blocks the Fc receptors, which are located on macrophages. This prevents them from destroying antibody-coated platelets. This allows for platelets to survive longer in circulation. Knowing that IVIG blocks the Fc receptor is going to be high yield and something I would know for test day. Now, of course, for children, we cannot use platelets to our advantage because as we age, our bone marrow matures and our platelet numbers change. Thus, there's no set platelet value to use. Thus, we typically use, are they symptomatic or are they not symptomatic? If they only have skin manifestations, the petechiae, the ecchymosis, etc., then we observe. These really aren't that big of an issue. If they're bleeding, any form of bleeding, epistaxis, gingival, GI, hematuria, then we'll treat them with the same exact medication regimen. Now, for refractory causes, people that do not respond well to IVIG or steroids, there are a multitude of different options. You can use such things as rituximab, but what you should know for test day is that if there's refractory ITP, typically the next step in treatment is going to be splenectomy. Splenectomy removes the primary site of platelet destruction and antibody production. Definitely know that the next step would be splenectomy. There are other options, but typically this is where they're leading to. That pretty much sums up ITP in a nutshell. There are some things that this is sometimes compared to, and I put this in table format. Hypersplenism, in which you'll see thrombocytopenia, splenomegaly, and typically pancytopenia, so low white blood cells and low hemoglobin as well. Liver disease, which can actually cause hypersplenism, will be an elevated AST, ALT, coagulation abnormalities, PT, INR, PTT, and sometimes hepatomegaly. Remember, we need to look for things that can cause a thrombocytopenic or ITP. One of those things can be autoimmune diseases such as lupus. If they want you to know what is this cause, look for ANA positive, which has a 96% sensitivity, or other systemic symptoms such as neurologic issues, photosensitivity, rash, arthritis, etc. And then, of course, TTP. Just briefly, TTP is going to be defined as both microangiopathic hemolytic anemia, also known as MAHA, and thrombocytopenia. If you have both of these things, you need both of these things, I should say, in order to diagnose TTP. You should also see schistocytes or other systemic symptoms. TTP will be covered in another lecture. And that concludes this lecture on ITP.